I spent the last year, from January of 17 to December of 17, doing nothing but work on the National Defense Authorization Act as it relates to Title VII. And if any of you have done work like that before, then you know what I'm talking about. If you haven't, then good for you. And I'll just leave it at that. So much like a residency training program, where at the end of it all you go, thank God that's over. I'm glad I did it, but thank God it's over. That's what I think about the year that I spent working on the NDAA. I'm glad I did it. I learned a lot. Thank God it's over. But we can talk about any of the topics within it that you want. So first is to explain to you how we got here. So since since 1947, there have been 17 studies that looked at how should military medicine be organized. 17 of them. So here comes the interactive part. What did those 17 studies say? What do they say that we should do? Okay, so some sort of integration. But in general, there's two major outputs that came out of those 17 studies. And 10 of them said there should be a unified medical command. And 5 of them said there should be an agency that takes care of this. And 2 of them said, well, we don't know what it really looks like, but it shouldn't be what that it exists today. It could be a unified medical command, it could be an agency, it could be something. It just must be different than it is today. There's not a single one of those studies that said, hey, the way you guys are doing it now, that's a great way to do it, keep doing it. And yet, it took 17 studies. Here's the other interesting thing about all that. If you look at those 17, of the 5 that said do an agency, 4 of those 5 were in the most recent 5 studies. So if you're wondering, well, then why, if most of them said unified medical command, why didn't we do a unified medical command? Well, that's why. Because from 1947 to 1995, they all said be a unified medical command. And from the mid-1990s to today, more often than not, they said be an agency. Here's the other thing about it. In the 1940s, 1950s, 1960s, how many agencies were there? By the virtue of the way I'm asking the question, the number that should jump to mind is 0. Okay, so one of the reasons those are dated studies, perhaps, is because agencies didn't really exist then. Okay, so 2013 is the most recent of those studies that said, oh, you ought to have an agency that manages that. Well, it just so happens then, the Secretary of Defense at the time said, okay, well, thanks for the study, then let's do that. So rather than wait for a law or do anything else, because the Secretary of Defense has that power, he did exactly that. He started this task force and said, hey, look at that study. It was a RAND study. Look at that study. If you agree with it, bring it back to me and tell me how you would organize it. So they did. And then that led to all this other stuff that you're seeing there, the planning memo and the planning work group report, that ultimately led to the Deputy Secretary, who gave this thing called the 9 Commandments that you don't really care about, and I'm fine with that. But the 9 Commandments are really shared services. Have any of you heard the word shared services before? Wow. Okay. So shared services are things that it doesn't really matter what service you're in, that it all looks the same. So like military construction, for example. Do we build Army hospitals differently than Navy hospitals, differently than Air Force hospitals? And the answer is clearly no, because we don't build them at all, right? We contract it out. So they can't be any different. So military construction is one of those shared services. What about from a pharmacy perspective? Are the medicines that we use in the Army work differently than the medicines that we use in the Navy, or work differently than the medicines that we use in the Air Force? Well, that's just silly, isn't it? So there's a total of 9 of those things. That's the 9 shared services, and they called it the 9 Commandments because the Deputy Secretary is pretty much the guy who makes the rules in the Office of the Secretary of Defense. This is what you're all going to do together. So he said, the Secretary said, we're going to have an agency, and that agency is going to be the one that's responsible for the existence of the TMA. It's going to do this shared services business, and we're going to transition what was then the Joint Task Force CAPMED, which came out of the 2005 BRAC, the base realignment and closure, and said it's not going to be a joint task force anymore because, doctrinally speaking, who knows what joint task force are? Doctrinally speaking, what is a joint task force? And you guys don't know your military doctrine. Come on now. It's time limited. A joint task force is supposed to be time limited to 5 years. So for those of you who work in JTF Bravo, sorry, it's way over time, right? The Honduras mission, how long has it been going on? 20 years, 25 years? If If you look at the joint task force that's operating out of Key West, that's doing the narcotics and smuggling interdiction, for those of you who work in the Navy, the Coast Guard, how long has that been going on? About 25 years. So sometimes we don't follow our own doctrine, but joint task force are supposed to be time limited. And so because that JTF Cap Med was supposed to be time limited, we got to turn it into something. So we're going to build an agency. We're going to put these shared services into it. We're going to put the TMA function, so the whole insurance business part into it, and the National Capital Region we're going to put into it. That's going to be the Defense Health Agency. And we'll see if it works. And then in 2013, October 1st of 2013, the DHA stood up. And that's what it is. So it's 4 years old, and that's it. So the Congress decided they had to do something in 2016, right? Because the 2017 NDAA was written in 2016. So why did they do that? Why do you think? Yeah, so almost everybody in military medicine said that too. Why did you guys do that? We don't understand all this. And the whole idea is that they believe that the work that was done from this wasn't enough. That we didn't do enough togetherness, that we didn't do enough rationalization, that we're not integrated enough, and that the only reason that we did it was to try to keep away from them, the Congress, but otherwise, too much waste, too much inefficiency, too much duplication of effort. And so they gave us a law so that the Secretary of Defense can't do whatever it is that he or she wants. This is the way it has to be. So this is what it looks like today. It's not what it's going to look like in the relatively near future, but this is what it looks like today. So in general, if you look at that, Army medicine looks a lot like Navy medicine, right? Looks a lot like it. Air Force a little bit different because of the way that their Surgeon General and their MAGCOMs work. For those of you who worked in Air Force facilities or worked with Air Force facilities, you'll see that it's actually operationally works about the same. But in the NCR, it's way different because we're an agency. So as I mentioned before, my job is that I'm the NCR Medical Directorate, so Walter Reed, Fort Belvoir, the Dumfries Clinic, the Fairfax Clinic, Joint Pathology Center, that's all my responsibility to deal with that, except I don't have command authority. And for those who've been commanders before, you know, command authority is a pretty big authority. Well, I don't have that, which means every soldier, every sailor, every airman who works there works in a separate command structure for uniform-specific command authorities. So, key point to learn, this is a huge deal for us, and most of the discussion that's happening in the DC area right now has to do with the differences between where we are now and what will happen when the Defense Health Agency has the responsibility for the administration and management of MTFs, but not the command of MTFs. And the reason for that is an agency can't command. So unless law is generated that says agencies can command, they won't. And I'm not going to get on the specifics of that. If you have questions about it, I'm happy to answer them. So shortly after the 2017 NDAA was signed by the President, the new Secretary of Defense, so President Obama signed the NDAA December 23rd, 2016, and then Secretary Mattis, in one of the very first memos that he signed, in fact, as far as we know, it's the first one, but you know, who knows, there may have been classified memos that he signed before this, but this is the first public memo, which is really what he's saying is this is how I want to be as the Secretary of Defense. And as you parse through that, you'll see a couple of different things. The first of which, and I have it pulled out there, is that he wants to rebuild the military. Now, he's a lifelong Marine, right? A lifelong Marine. Started as an infantryman, ended his career as a 4-star infantryman. If you ask him, that's what he'll tell you. And the one thing that he wants our military to be is what? More lethal, right? I mean, so lethal, in fact, that nobody ever wants to fight us. Now, as a father of 2 Army officers, one of whom is an armor officer who just got back from 9 months on the DMZ in Korea, I'm pretty good with that. Now, I just assume that my son wasn't shot at or someone didn't use some sort of anti-tank weapon on his tank. I'm pretty good with that. But the number one priority for the secretary is to be more lethal. And the number two priority of the secretary, again, as you read this document, and I made it easy for you to see, is to rebuild, right? To rebuild our structure, to rebuild the things that make us a better military. Now, in so doing, he says that we need to reform a bunch of this stuff, this business stuff. And believe it or not, in the secretary's eyes, what we do is a business. And he's got 8 of them up there. If you want to read them all, you can see them all. But that's what he says, that we're going to reform our part for 2 different reasons. Number one, so we can support the lethality better. And number 2, so if there's extra resources within that reformation, those resources can be reinvested in the lethality part. That's the whole goal. Now, to make that happen, he has help, right? The whole Office of the Secretary of Defense. And the person who runs the Office of the Secretary of Defense, believe it or not, is not the Secretary of Defense. It's the Deputy Secretary of Defense. And who is the Deputy Secretary of Defense? If I hadn't told you Mattis was the Secretary, would you have been able to come up with that? Okay, who's the Deputy Secretary? This matters. Okay, Shanahan is his last name. Let me ask you this question. What was his job before he became part of the Department of Defense? And I'm going to look at my Air Force brothers and sisters here, because if you don't know, this is a problem. Okay, he's a CEO of Boeing. He's a CEO of Boeing. Why does that matter? This really is supposed to be an interactive discussion. Yeah, he's a businessman. So this whole reform thing, Secretary Mattis specifically picked someone from business to handle the business reformation. And after about a month, I was at a meeting that Secretary Shanahan was leading, and he was just shaking his head over and over and over again. He said, I just can't get this. I don't understand. Why in your budgets do you think that you have to have inflationary added to your budget every year? I don't get that. And of course, all of us in the military look at me like, well, you don't understand math? I mean, what do you mean you don't understand that? He says, at Boeing, everybody's budget is cut between 2% and 5% every year. Doesn't matter what inflation is, everybody's budget is cut. My expectation is that managers will become more efficient at what they do. My expectation is that they'll figure out how to do it with less money every year. And here's why. Because we also have new things that we're going to do every year. And we got to get money for that from somewhere. It's got to come from our existing budget. We can't print it like the federal government can. So everything always has to get more efficient, always. Why don't you do that? He's saying to the military leaders in the room. So if you're wondering perhaps why some of our budgetary challenges are going to be there and why the Defense Health Program budget, which is how we get our funding, why that's being cut, that's why. His expectation is everybody always gets more efficient. And then he gets to decide, or the Secretary gets to decide, where to invest more of that. Now, for those of you, so none of you are comptrollers, right? Is there anybody who's a comptroller in here or financially trained? Excellent. So I can say what I want. That's not really the way the federal budget works, right? Because an Authorization Act says you can do anything you want as long as within the boundaries of what this authorization says. So the authorization will tell you what you can't do, but otherwise, as long as it seems like it makes sense within the broad scope of what that Authorization Act is, you can do it. Appropriations are different. Within federal appropriations, you can only spend the money in the way that the money guys say that you can spend it. So the Authorization Act is one thing, Appropriations Act is a different. Hopefully they say the same thing from a money perspective, but at the end of the day, the Appropriations Act is the only one that matters from a money perspective. And if they say you have to spend $50 billion on healthcare, then $50 billion has got to be spent on healthcare. So you got to figure all that out. So it's not exactly what the Deputy Secretary wants to do, which is, I get to spend it how I want. But within broad limitations, he really can. And there's a lot of O&M money, and if you know what O&M means, then great. If not, operations and maintenance is what it's called, but it's really the general fund. And even within defense health programming money, so that $50-ish billion that goes every year to the Department of Defense for all healthcare that we do, to include the TRICARE thing, a whole bunch of it is O&M money. And so it's fungible. You can use it for really whatever you want. Okay. So this is what the NDAA says. This is what we're going to do. Now, essentially, it says that the Health Affairs, and therefore the DHA, is going to manage budget IT, policy procedure construction, et cetera. You know what? Those are the shared services already. So that didn't matter. The only thing really that's different is that third bullet, and that's the healthcare administration and management, to include the management of the MTS. So that's the what. Secondarily is the why. This is why they say that we're doing it. They say that we're doing it to get better at being ready, by the way. In fact, that's first in the law. So if some of us think, well, no, it's going to destroy our readiness, well, that's not the Congress's intent. They think that this is going to lead to better readiness. They said it in a couple of different ways. And they also believe that access for our beneficiaries is going to get better. They also believe that satisfaction is going to get better. They also believe that health outcomes are going to get better. So they believe that the law that they made is going to do all these things. So if you think there's nefariousness in the members of Congress, that's not their intent. This is what they want to have happen. Now, we can spend as much time on this or as little time on this as you want. But Title VII actually has 40 parts. And everybody's focusing on 702, at least in the DC area. I don't know if you all even care about it. But if you do, that's the one that everyone's focusing on. And 702 is Reform and Administration of the DHA and Military Medical Treatment Facilities, right? So instead of the service surgeons, or in the Air Force's perspective, the MAGCOMs and the wings having the authority of the military treatment facilities, it all goes to the DHA. Okay, that's 702. I'll argue that's one of the less important parts of the law. Now, I can tell you what our retirees think is important in 702. I get way more information and way more constructive feedback from our beneficiaries on 701 than 702, which eliminates TRICARE Standard and TRICARE Extra and makes it only TRICARE Select. And the only way to be in TRICARE Select is if you pay for it. I don't know if y'all know that or not, but there's no more free health care. And then you can be standard and pay for what you want, don't pay for what you don't want. If you're going to be in the TRICARE system, there's an annual fee for it. So our retirees, they care way more about 701 than they do 702. 702 affects us, though, right? It's an emotional issue for us. So I can talk about that one. Or 703. Anybody know what 703 is about? 703 gives a definition of a medical center, a definition of a community hospital, and a definition of an ambulatory care center. And unless you meet those definitions, you can't call it that. It also suggests that we should redo the MODS study, it was called. And the MODS study is the thing that led to the closure of a whole bunch of community hospitals across all the services. It asked for another one of those. That's due at the end of this calendar year. That's what 703 is. 707, go ahead, yeah. Yeah, I don't think so, actually. The copays within all the parts of the TRICARE system are significantly increased. That's for care, that's for pharmaceuticals, it's for everything. So part of what the Congress is trying to do, and the Department of Defense for that matter, is to make people get off the fence. You're either in the system or you're not. And I can tell you that's the driver behind it, at least from the Senate Armed Services Committee. The other challenge that goes with it really is the annual fee. For those of you who are not aware, the annual fee has not changed since TRICARE started. So in 1994, which is when the first element of TRICARE first started, it was about, 15% of the annual cost that was projected for a retiree family member was what the TRICARE fee was. And there was huge pushback. Dr. Hetz can probably talk to this more than I can, but huge pushback by our beneficiaries at the time that you promised me free health care forever. And how could you possibly say that I have to pay $200 a year for health care? Huge pushback. And so because of that, the Congress Department really didn't want to address it a whole lot after that, just sort of let it go. But now that it's down to about 4% of the annual cost of health care, it's like, okay, something else needs to be done. But But to the bottom line, I think that's really what the Congress is looking for. Either you're in the system or you're not. Pick one. Whatever it is, that's fine. So 707, 708 talks about, no kidding, how we're going to do the joint trauma system, right? Those of you who are working on it, you know exactly what I'm talking about. What about 706? What about that? What does that mean? Establishment of high-performance military civilian integrated healthcare delivery system. What does that mean? Or what does, I may come back to one of these other ones, what does 717 mean? Evaluations of veterans and civilians at military treatment facilities. What does that mean? So Dr. Martin says increasing our volume. Maybe. Yeah, I think it probably will increase volume. But it's really, again, this gets back to the readiness thing that the Congress said. What they said was what 706 says is that if you could get better at your readiness by putting your uniformed people somewhere else, you have the authority to do that whenever and whatever you want to do. If that's, and it's all about readiness, by the way, that's what 706 says. If you believe we'll have a better ready medical force by having our uniformed staff, physicians, nurses, technicians, whoever, doing some sort of training episode, some sort of thing that makes them more valuable from a readiness perspective, Secretary, you have authority to do that. Broad-based. 717 is exactly the opposite. Secretary, if you think that there are patients that if only you had more of them, whatever it is that they have wrong with them, if only they could get care inside your MTF, the readiness of your uniformed personnel would be better, you have the authority to do it. Holy cow. That's extraordinary authority. So the Secretary of Defense, and unfortunately it's non-delegatable, if the Secretary of Defense says, this is the way we have to do things such that our readiness is better, he has that authority. Well, that's extraordinary. So some of the comments that I said in our brief lunch today, or I'm willing to talk about it here now if you want, those authorities say, figure out what it takes for us to be able to do whatever it is that we think we have to do, and what's the working milieu that's required to make that happen. We present that through our organizational structure, through our chain of command or our chain of authority, if you work in the DHA. Those are actionable things. Subtitle C, 721, which is it's labeled as the military mil-to-civ conversion. And that's within that particular paragraph of the law, but it's actually much more expansive than that. What it really says is Army or Navy or Air Force, however it is that you think you should have the right specialties, officer specialties, enlisted specialties, whatever they are, at whatever strengths and whatever ranks that you think that you should have, you have the authority to convert to that. Here's a caveat, you can't grow. So if you think that you need 3,000 general surgeons and no family physicians, you have the authority to do that. Or vice versa, whatever it looks like. Or if you think that we don't need nearly as many, pick your specialty, in uniform, but you still need them to run your facilities and to handle to manage the healthcare benefit, right? The treating of our family members and retiree family members, that you still need them, but you don't need them in uniform. You have the authority to convert any position you want to civilian, any of them. Or my favorite one up there, 725. Does anybody know what 725 is? We want to take a guess. I'm doing all the talking. I don't like it that way. Sure. Yeah. Yeah, I'm using specifically the Secretary of Defense. I'm talking the Secretary of Defense. And when I said it's non-delegatable, I mean that. None of this is delegatable.
indigents from across the border who really get no health care, but your military facility could really offer them great benefit and would be great benefit to your resident. And a Surgeon General goes to the Secretary of Defense and goes, yeah, do that, and it happens.
True fact. True fact. And I'll go one step further. Just for the life of me, I can't figure out why all of our bedded facilities aren't trauma hospitals. I can't figure that out. Well, they're all bureaucratic reasons.
Nursing services, other services that basically contribute to that level 2 trauma or whatever, they go, hey, wait a minute, this is too hard to do, this is too hard to do, this is too hard to do. And though the surgeons are interested, we can't really do it without help.
Yeah, amen. So Dr. Hetz, you were luckily, I guess, probably not at the lunch that I talked about. But one of the things that I think is a problem is surgeons not being in leadership positions. And I recognize that you sacrificed a fair bit of your surgical career to be the deputy commander at Beaumont for a while and those sorts of things. But I believe that people who don't understand what it really takes to be successful in combat, if you don't understand that, then you probably ought not be leading our MTFs here either. Because if you don't understand what we're for, and ladies and gentlemen, I got news for you. What we're for is combat. That's what we're for. Now, we do humanitarian missions as well. I get that. That's goodwill. But whose job is that really in the federal government? Whose job is that? Department of State. And when they can't do it, then they come to us and ask for help. And if we have the ability to do it, good on us. But that's not what we're for. What are we for? Well, seriously, if you don't know what you're for, then good Lord, what are you doing here? We're here for our brothers and sisters in combat. That's what we're for. Now, that's not means that only general surgeons are for that. I mean, we've got a whole bunch of psychiatrists that we need for that as well. And for those of us who deployed, we understand there's a huge behavioral health requirement in combat as well. And it's great to have orthopedic surgeons there with us too. And if we didn't have great anesthesia support, that'd be a problem. I mean, I can go on all kinds of things, but combat casualty care, that's what we're for. And the tail's been wagging the dog for a long time. What's the tail? In my metaphor, what's the tail? Beneficiary care. If you look at the way that we're task organized, if you look at the way 721 works, each of the services have a formula. I know the Army says Total Army Analysis, TAA. Navy's, I think, is MedMaker, and the Air Force's is... I can't remember. Sorry about that. But it's fascinating how at the end of every single year, what comes out of that formula is exactly what you have. Are you kidding me? You know, where I grew up, that's called cooking the books. But that's how it gets done, is what it takes to handle garrison care. That's the way that we're task organized. That's the way that we are in uniform. My opinion, again, not the opinion of the Department of Defense, Ron Place's opinion, we are task organized to handle garrison care. That's not what we're for. And so, if we have leaders in our organization who not only have never been deployed before, don't understand what it means to be deployed, and don't understand what is the stuff that when we're deployed, and then somehow we're surprised when decisions happen that are not consistent with what we're truly for, well, I'll advocate for there's no reason we should be surprised. We should understand that. Now, that isn't to say that in those organizations that were led by people who've never been deployed and don't understand what that means, or when they are deployed, they're deployed to places where not a whole lot of combat casualty care was going on. Our job then is to advocate for those who understand what it means. And sometimes we do it effectively, and sometimes those leaders just don't want to hear it. I get all that. Yes, sir. Yep.
One of the problems with, I think, that can occur with that mindset, and not you, it's just that mindset is, then we start looking at what are the other things that don't directly support combat casualty care. And one of the things that starts to pop up in terms of numbers and money is graduate medical education. somehow the military or somebody on housing can decide that crap is ancillary. Let's just get doctors that can take care of patients in combat. And the truth is, without resident and graduate medical education, the culture of that gets lost. And I'd be greatly concerned as we whittle away at the edges, we're not going to be able to train what we need to train to do what we need to do as an Army or as a military force.
Yeah, as two old Army guys, you and I can agree on that. One of the things that we know is that about 95% of Army GME happens in Army facilities, right? Those are your Army guys, right? About 95%. Maybe down to 92% at any particular year, but it's north of 90%, right? Okay. Navy team, is that the way it works in the Navy? No, it is not the way it works in the Navy. In the Navy, it's about 60, 65 in, 35, 40% out, right? Navy team? Lower now? Okay, lower now even. So maybe 50-50? Okay, so 50-50. He says 48. How about in the Air Force? How much do you do in-house? How much do you do out-of-house? You know? Yeah, it's 30-70. 30% in, 70% out. So I don't know, Dr. Hetz, I don't know the ramifications of doing it in versus out at this point. So from the Air Force's history, from 15 years or so ago, when it was much different, it was 80% in, 20% out, to now 30% in, 70% out. For those things that have been investigated in terms of what's the quality of care given, board certification rates, staying in the military, et cetera, all the things that they've looked at hadn't made any difference. So while in my gut, I agree with you, there's culture that matters, and I believe that in my soul, there are no data points that seem to indicate that. Yeah?
So going along the lines with graduate education, with the DHA, the NDAA, where does that fall? Who's going to own that, and who's going to direct it?
Read 749. So 749 says the DHA will be responsible for graduate medical education. What's the problem with that? I mean, other than, you gotta be kidding me, but aside from that, what's the problem with that? Well, that's right, they don't have a command authority, and so without command authority, what does the whatever in the service, so from the Army and the Navy perspective, I think it's true of the Air Force as well, but I'm not going to go that far on a limb based on the Office of the Surgeon General for the Air Force is specifically the Office of the Surgeon General, not a command authority. What is Title 10 no kidding authority for the services? What does that mean? Other than, hey, when you're deployed, you take care of anybody that you want as long as the task force commander says you're going to do it. What else does it mean? What's the requirement? Title 10 gives the service secretary and the service chief, delegated however they want within that authority, to recruit, organize, train, and equip. That's what Title 10 authority really is. It's not life, limb, and eyesight like we think about it. It's recruit, organize, train, and equip. And they're not only authorized to do that, they are required to do that. So if graduate medical education is, someone else is responsible for that, well, who recruits that? Oh, wait a second, I thought that was a service thing. Who trains that? Oh, wait a second, I thought that was a service thing. Right? So there's some dichotomies of authorizations and authorities that are a problem with this particular law, and that's one of them. 749, graduate medical education, is something that the whole military health system in the senior leader perspective is at loggerheads about how to do that. And I believe the way it's going to sort out is the services are going to keep that responsibility with some sort of oversight body within the Defense Health Agency to make sure that the right resources are present for wherever those graduate medical education programs are, or for that matter, graduate dental education, phase 2 IPAP, phase 2 enlisted training, all that stuff, because it all matters, right? It's not just, it is all about us as physicians, but it's really not all about us. But all of those things, I think, are going to maintain from an authority perspective within the services, but there'll be some sort of oversight mechanism, oversight council, some bureaucracy thing to make sure that it's being done as efficiently and effectively as possible. And that's the oversight authority, I believe, that the Defense Health Agency will have at the end of it. I think that's the way it's going to sort out, but I don't know. Lance. Yeah, and it's more than MedCom, it's more than BUMed, it's more than AFMOA. Here's one of our problems. We lose horrific amounts of money when we take care of civilians. We just do. Why is that? Because we don't have the right billing systems. Maybe if we had a coder, big deal, the billing system didn't work. And so one of the reasons that the Tacoma Trauma Trust that gives millions, truly, right, it's a line item thing in the budget every year. The reason for that is because without it, it'd be a multi-million-dollar loss for Madigan to do the right thing. My guess is Beaumont, you dealt with the same thing. I know in San Antonio, at San Antonio Military Medical Center, that's all I can do not to say Brooke, but the San Antonio Military Medical Center, that's tens of millions of dollars a year that goes into trauma care because we don't have the right systems to do the right sorts of billing. How many of you, well, maybe I shouldn't ask this, but how many of you moonlight and are willing to talk about it? Okay? Are the systems that you use when you moonlight significantly different? And is the organization set up to do line item, I can't believe I'm forgetting the name of the thing. What's that? What's that? No, well, maybe it's HCPCS, I don't know. But from a logistics perspective, where you just scan in every single piece that you use for everything. Well, it's not just line item billing, but the processes that are set up to be able to allow you to do that so you're not hand jamming everything all the time. And if we really looked at our pick lists and said, oh my God, do you realize how much that stuff is? I mean, how many of you even know how much stuff costs that you use? I mean, a lot of us don't. And yet somebody's paying the bill. And so our system, both from an electronic health record, those of you in Madigan, your new electronic health record actually is set up to do that. But if we had the right logistics systems that went along with it, and the coding system that actually belongs inside that commercial off-the-shelf product will allow that to happen. There's actually some goodness that comes from that. But it's more than just trauma. I mean, isn't critical care good for all that we do? Isn't it? I mean, it's all about complex casualty care, isn't it? And it's a thought process. I mean, I'm not going to argue with the 10,000 hours thing, but I think there's a whole lot more to practicing surgery than being in the operating room. I think most of it's in your head. Now, there's a great quote from Eisenhower, and I'm not exactly expecting you all to know this, but probably the greatest planner in the history of the United States military. And what's his most famous quote about planning? Any of you know? Or you just know his other quote, no plan survives first contact, or the Mike Tyson version of that, everybody's got a plan until they get punched in the face. He's got a planning one as well. And that is, the plan doesn't matter. It's the planning that matters. Why is that? It's critical thinking. So I get it. Operating's the fun part. You want to keep track of how many hours you're in the operating room, good for you. But I think what happens in here is way more important than what happens here. And so if we're good at critical thinking, then what about those strokes, or what about those STEMIs, or what about those critical sepsis patients that are outside, that drive by our gates and don't come in? Would those help us? I'm absolutely positively convinced that they would. And is it really helpful to do 250 inguinal herniorrhaphies? I'll wager that from a residency perspective, that early in your career, those are great cases. And I also agree with Dr. Hetz when he said they're great teaching cases as a more senior resident. But 40% of our time in the operating room taking care of hernias is probably not where we want to be. We probably want more decision making. thinking, cognitive analysis, irrespective of the disease process. Yeah, so the answer to that question is about a 2-hour talk that the Chief of the Army Medical Corps gives. I'll try to do it in 2 minutes or less. The first of it is 721 gives the authority to change. Well, let me back up a second. First, the lift, from a general surgery perspective, the lift is heavier for the Army, it's next for the Navy, and it's least for the Air Force. That isn't to say that all aren't deploying at rates higher than most every other specialty, because they are. Army perspective, the two most deployed specialties, believe it or not, are PAs and emergency medicine physicians, followed very closely by general surgery from an emergency medicine physician perspective. But again, all the services are deploying relatively harder as a general surgeon than almost everyone else. So you're right about that from your observation. Secondarily, 721 again gives the service surgeons the ability to reorganize how they want. Every single one of the services has indicated that they need somewhere between 2 and 3 times as many as the general surgeons that they currently have. Each of the Army Surgeons General have indicated that they know they don't have the bandwidth in the MTFs that exist in the military health system today to keep that many surgeons busy, which goes back to that 706 perspective. Then how do you do it? How do you get surgeons in other locations to be able to be productive and working general surgeons? 717 comes into that as well from a VA perspective. And so if VA patients are coming to us, then is that a good way? Or do we put significant components of uniformed people within VAs collectively as a group? And not for a month or so, like we send people to our trauma centers, but maybe we should do it for 2 years. Send the whole group there. And maybe we should have them working together. Now, when they go to the operating room, then it's a uniformed OR technician, and it's a uniformed scrub nurse, and it's a uniformed anesthesia provider. And in the post-anesthesia care unit, it's uniformed folks who are doing that. So in some form or fashion, we have to get a whole lot more of the stuff that we say is important, the combat casualty care stuff. We have to figure out how it is that we can keep them ready. We have to figure out how it is that we can deploy people even from those locations. We don't send them there for a month or so, because I don't know about you, but when I go to those kind of places, I'm still not with my family. So how do we make that an actual rotation? So that it doesn't matter if you're in uniform, it's not just the Chicago location that we're co-located, or the Nellis Air Force Las Vegas where we're co-located. There's a whole bunch of different VAs. And maybe we ought to do it in places that are both level 1 and level 2 trauma facilities. So the stuff that's coming in is actually relevant to what we do. And oh, by the way, if we do it in the best of the VA polytrauma units, then that same sort of rehab stuff, just like we're doing at Walter Reed or San Antonio Military Medical Center, that stuff can be done there too. And so it's a combination of all those things. But we're going to do a whole lot less of the uniformed people that it takes to run a hospital or a medical center, but who don't deploy, and a whole lot more of the folks who actually do deploy. Some of them may not be within the in the military health system to be able to do it. I'm going to get the hook here in a second.
The other issue, obviously, is most of these people who deploy, honestly, when they deploy, some of them are even good with it every 12 to 18 months. If they actually did.
Yeah, that's a completely different story. So, yeah, I get that. Here's the thing.
Well, my question is the communication between the medical leadership and the military leadership. I know the golden hour concept. I think that's sometime in the past that, we have to have a surgeon or surgical capability within 1 hour of any soldier that might be around. It really seems to me that's putting the cart before the horse, because military mission, if you actually have to have a surgeon there all the time, you don't have enough of them.
Yeah. Yeah, and again, this gets back to having surgeons in leadership positions. So our current Surgeon General in the Army is a dermatologist. That's great. The Navy Surgeon General is a developmental pediatrician. The Air Force Surgeon General, I believe he's a family physician. And that's who's leading our services right now. And they're brilliant people who don't understand a lot about combat casualty care. That's a problem. So I made a relatively impassioned plea at lunch today, when almost all these folks were there, to say how surgeons have to lead. So that's the first answer to that. The second is, we also have to be able to speak military speak. We have to be able to talk about gaining readiness and burning readiness. And so every time we send a surgeon to a place where they don't operate, we're burning readiness. We're burning it. So if you go to Africa for 4 months, you don't do anything, my readiness is burned. I'm out. I'm out, right? Because if we do that with my son as an armor officer, we send him somewhere and say, sorry, no tank for you. You're going to do humanitarian stuff for 4 months. He comes back at what level? What's his DERS at that point? He is not ready. And there's nobody who's going to take his tank company and say, okay, dude, back on the Fulda Gap you go. It doesn't matter that you're not ready anymore. Get in your tank and go. They don't do that. Well, we haven't effectively spoken Army talk or Navy talk or Air Force talk to be able to talk what real readiness is. I'll argue that when I backfilled at Fort Irwin as a general surgeon when I was at Madigan, I had to go down there for 3 months. I was burning readiness because I'm not doing anything down there that's keeping me current. I'm just not. And so sometimes you're deployed, you burn readiness. Sometimes here in the CONUS, you burn readiness. And we have to be able to talk those different languages. So I think it's all of those different things. Yeah.
Sir, I'll use the mic. Is it on? So thank you for what you've been saying. My question is, you've asked surgeons to be in leadership positions, which I agree with. But there's a problem with that from our point of view, is that you lose the clinical aspect of things.
Only if you're willing to give it up.
Well, I would argue.
I can tell you that Dr. Hetz operated as a DCCS, operate a lot. I can tell you I operate a lot as a DCCS. I can tell you I operate a lot as a commander. You give it up if you want to give it up.
Well, I would respectfully disagree with that, but that's okay. But my point, I think, ultimately, to make that bigger change, though, to even go beyond that, beyond the DCCS, because you, yes, can be a half FT or 0.75, however you want to do it. But in order to do that and clinically be effective with what's happening in the field, that's where I think you lose what's going on, downrange or further in the austere areas. And so my question is, how can you maintain both, or how, maybe you don't have to, but do you have a better connection with what's happening out there? Because what I see is frustration from my end, and I can have all the symposiums I want and help out and get people to come here, but until those two ends meet, it's going to be very difficult.
Yeah, Rob, I'm being a little bit flippant, and I don't mean to be, or maybe I'm being provocative on purpose. Yeah, I do mean to be. I honestly do believe that we control our own destiny. And I can tell you that I was asked to do a whole bunch of administrative things when I was the chief of surgery at Launch Stool. And every time I would go to the commander and say, okay, I can do that. And then who's going to operate? Who's going to see patients? I would rather do that. I'd rather you find, and you have to be careful about what those things are. But I believe that we can say, sorry, in my cut line of 70 hours a week, that falls below it if you want me to continue to be clinically active. And I think you, sir, you want your chief of surgery to be a clinically active surgeon. I think that. I think, sir, that you want your deputy commander for clinical services, your SGS, I'm thinking of the Navy term, blanking on it. What? Say it again? DSS, right, Director for Surgical Services, thank you. I think you want him or her to be clinically active, yes? If that's the case, then these are the things that I believe fall below the cut line. And you have to you have to assert yourself. But for God's sakes, we're general surgeons. If not us, who can assert ourselves? I mean, that's our reputation, right? Now, I'm not saying being a jerk about it, because that's also our reputation, but we have to assert ourselves and say, I think that you want someone who's clinically active. I think we make fun of other staff who stop being clinicians as they get up in rank. Okay, well then don't be that guy or don't be that girl. Be clinically active. And you have to come up with a plan. This are the things I'm not going to do. I can suggest to you who I think ought to do it, but I'm not going to do that because I think you want me as the chief physician of this hospital to be clinically active, and that's what it's going to take. Or as a commander, I think it says tons to the staff if you find ways to be clinically active as a commander. I think they want a clinician to be their leader. That's what I think. And so I'm not saying that it's easy, and I do understand the challenges that come with it, but I think you have to assert yourself.
We're going to finish with the questions. Major General Place, I really want to thank you for contacting. So he contacted the military committee, and we were able to find some time for him to address the audience. Of course, it's been very educational.
That's right. So I asserted myself into this program, just so you know.
It's not the most exciting to talk about NDAA 217, but super important, and I really appreciate the question and answer session here. And I know you didn't want a formal session, but we'd have a formal plaque, so I want to thank you.
Oh, it's my pleasure. Thank you. And then I'm here for the rest of the day or the rest of tomorrow. If you have compelling things you want to talk to me about, I'm more interested in what you have to say than what I have to say, but I'm willing to talk to any of you, either outside or at one of the other things. Thank you.
All right, thank you. Yeah.